Tennessee, and then did his pediatric residency in genetics and metabolism fellowship at Vanderbilt University, where he then stayed on as faculty. In 2010, he moved to Children's National in Washington, D.C., joining the faculty of George Washington University, where he became the chief of the Division of Genetics and Metabolism. And I met him back in 2016, just as he was being named the chairman of the board of directors for the National Organization of Rare Diseases, and where he served as the chair of the organization's Scientific and Medical Advisory Committee. And then in 2012, he actually became the director of NORD. And also very exciting, and still seems recent to me, although it actually is now becoming more of a historical note. In 2017, Children's National became the Children's National Division of Genetics and Metabolism grew into the Children's National Rare Disease Institute, a center dedicated to improving care and treatment for children and adults with rare genetic diseases. And it ended up being designated as the first rare disease center of excellence by the National Organization of Rare Diseases. And it was a great pleasure to invite Marshall, because now University of Minnesota is one of a new crop of rare disease centers of excellence. And so we're very excited to have Marshall here to talk a little bit about rare disease. Although he's recently stepped down from the NORD directorship, he remains with the Scientific Advisory Committee, and it is a great pleasure to have him come and speak to us today. Thank you so much, Marshall, and we're looking forward to hearing more.
Thank you so very much, Charlie. And good morning, everyone out there. I can't actually see you, but I will talk to my screen and pretend I can actually see you. So we'll do it that way. Charlie was our gift back to your university. He was one of our outstanding fellows. He's exquisitely well trained, and he's going to take great care of your patients up there, as I know you're already finding out. The picture I'm starting off with is actually our new facility for our Rare Disease Institute. This is on the former Walter Reed Army Medical Base. The giant concrete building in the back behind the garage there was actually built in 1955 as an atomic blast resistant building, which is where my labs are now. And given recent times, actually, I'm starting to appreciate that more and more. My theme for today is how rare disease is emerging as a unique field of medicine. So why do I say that? Well, the conditions, which are mostly all genetic, and we'll just stick with the genetic rare diseases today, but they're also lifespan in nature. You know, the genes you get are the genes you kind of keep. And while we may try to edit and change some of those with time, you still are stuck with those. And like a lot of disease where it's transient, you can get sick, hopefully get better, and then you move on from there. The diseases aren't always limited to an organ or a specific system. With all the different conditions we have, they really do hit every aspect of medicine. As Brendan Lamb, a colleague, put it, we're sort of the world's most highly specialized generalists. Evidence for what we do is based on very small numbers. If you're looking at hypertension, the numbers may be millions or hundreds of thousands, in a small study. Our incidence data is very limited. That's why you'll notice we'll say 1 in 1,000, 1 in 10,000, 1 in 100,000, because we actually don't have tight enough data to know how often a lot of the diseases we deal with are. We have limited outcome data. Given the genetic heterogeneity of so many of these conditions, where each patient has their own sort of bespoke molecular change, there's a lot of clinical variability. So our outcome data really can be quite broad, from neonatal onset of severe illness to not presenting in the 8th or 9th decade of life. Also limited natural history data. One of the big pushes we've been doing for the last 20 to 30 years is actually building natural history studies so that we can do a better job with knowing where we're going with our patients. One thing about this field that I think is very unique is our patients and families are actually often our best sources of information about the disease that they have. We have thousands and thousands of conditions, and these families actually are the ones sometimes that are the ones that know the most about them. Our care models are complex and usually involve multiple specialties. I tracked what specialties our patients used against others we use more specialties and our patients see more specialties than really any other patient population. And care expertise is limited. It has been traditionally an academic, research-based field. And I would say our workforce has had some challenges we'll talk about later. The way we kind of deal with our patients with symptoms, we try to come up with a specific genetic disease and then try to do a treatment plan. That part's not so different from other things. So let's talk about rare disease definitions, because actually there are legal definitions and they vary depending on where you live. If you're in the United States, it's under 200,000 in the US population, which is about 1 in 1,600. There's an estimate that about 8 to 10% of the US population has some form of a rare disease. I'd say a more realistic number for rare diseases that actually have some impact or significance is about 3 to 5%. And the data is really starting to back that up. We've currently identified over 9,450 phenotypic conditions in OMIM and other sources. So the number of conditions we've got is huge. In Europe, they actually use a 1 in 2,000 number, so a little bit less common there. So that's about 1 in 370,000. Taiwan and Japan uses 1 in 10,000. Their NIH estimate is about, their National Health Institute is about 0.03% of their population, but they have an official list of only 220 diseases. Western Australia uses something similar to the European. My definition, I think it's a good working one, is a disease uncommon enough that a general practitioner wouldn't be expected to be very familiar with it or how to treat it. Here's the thing that will really kind of catch your eye, I think. So from 1989 to September 2021, we have officially linked 6,934 clinical phenotypes to a genetic variation. Actually, the number is much more than that. This is just what has made it into having a text description in a particular database. The number is probably north of 8,000 right now, but we'll just use that 6,900. That means 4 new diseases a week since 1989. The acceleration in this process really occurred around 2000 when we finished the draft of the human genome. Since then, since 2000 to now, the average is 10.7 new conditions where a genetic change is linked to a clinical phenotype every week. That makes us very different from your classic medical practice where the physician is expected to be the master of all of the conditions in his field and what to do with them. With ours, I miss a week or I go on vacation, I come back, I'm way behind. There's so many new things. So we're probably more informatics based and more informatics dependent than almost any other field in medicine. So I sort of like to reckon it to riding Hokusai's wave in the Mount Fuji series, but what I'd like to think is we've got some great jet skis to kind of get us out of trouble. What's happening with prevalence? We talked about the incidence. And when I talk about that incidence, it's not that those are new conditions. It's just we're taking diseases that previously did not have an underlying pathology and actually finding one. With prevalence, what we're finding is our patients are living longer and longer. This is some data from Spain looking at mortality rates for patients with congenital abnormalities. And it's been going down and down and down every year since 1999. And as you can see, it's almost a 5-fold decrease in mortality for their patients. And this is really a trend. Down syndrome, which is kind of borderline, but kind of depending on where you are, whether you call it a rare disease or not. In the 1980s, the median survival was about 25 years. In the 90s, it's 50. Today, it's actually approaching 60 years of age. A lot of that has to do with better monitoring, correction of the cardiac defects, things like that. Sickle cell anemia with the advent of the National Sickle Cell Act, use of penicillin, transfusions, hydroxyurea, and lots of other new things actually has had a dramatic increase in survival, as has cystic fibrosis. And what's interesting is while some of these are due to new therapeutic options, you can track to the clinicians and the parents getting organized around how they were treating and starting to compare best practices. Comparison of best practices and standardizing care has power to improve the survival of rare disease than almost any of the new medications. There are some great exceptions to that, particularly in the lysosomal field, but just keep that in mind. Another trend we're seeing is we're taking common diseases and we're breaking them into smaller and smaller groups where basically they resemble the rare disease statistics and clinical thing. Breast cancer is a good example, 150 cases per 100,000 US population per year, but those have now been broken down into 30 molecular subtypes of about 8,500 per subgroup, which actually starts to bring you into that rare disease area as far as numbers go, things like that. And we're going to continue to see this trend, whether you call it precision medicine, personalized medicine, whatever you do, we're using genetic information to parse common diseases into smaller groups to better target therapy. Let's talk about the economics of rare disease. This is something that more important as we go along. As you can imagine, when it was just a handful of diseases, we really kind of came under everybody's radar. Now, though, that we have thousands and thousands of conditions and about 600 therapies for those conditions, we're actually starting to impact the healthcare system enough where we have to pay attention to this. So one question I get asked a lot is, how much does it cost to treat a rare disease for orphan? And we'll use the data from orphan disease, which has about a 80-90% overlap there. It's about $97,000 a year. Now, compared to a non-orphan regular disease being about $15,000 per year. So there's definitely a cost increase there, and that's been fairly consistent. It'll bounce around by $5,000 to $8,000 a year, but these patients do cost more, which insurers are starting to pay attention to. We've also really added a lot of therapies for our patients. We've got organ transplants, enzyme replacements, small molecules, substrate product manipulation, enzymologies. We're using things like bacteria, things like that. Messenger RNA manipulation, which of course we all got great experience with over the last 3 years with the vaccines. Gene therapy, which has been around since the mid-'80s, and we used to say gene therapy is always 5 years away, but we actually have done a couple that are working now for spinal muscular atrophy, and then some of the ocular retinal diseases. Gene correction is sort of the new hot topic, where instead of adding in working copies of the genes when they go back and correct the defect originally, that's, I would say, that's an emerging technology that's going to take a lot of close scrutiny before we go back and start using it in patients. And then just simple things like dietary manipulation. If you have a fatty acid oxidation defect where you have trouble making glucose, guess what? We can give you more glucose. So there's lots of different ways to look at these things. The Orphan Drug Act is worth thinking about because it was set up as an incentive program. And I think you could argue the point is probably one of the most successful government incentive programs in history. It's passed in 1983. It was for diseases with under 200,000 patients. Companies who were bringing, or the investigators bringing drugs forward to FDA trial got special consideration. They also got an extension on their patent life. They got market exclusivity for a few years. And it really has proved highly incentivizing. And I'll just show you a couple of examples. One of my patients was wearing this necklace one day, and I just thought it really kind of sums up how I feel about a lot of my patients. I love working with them. You can read that while I tell you about the other. In the United States, potential years lost to life to rare disease declined at an annual rate of 3.3%. And their best modeling shows that without the Orphan Drug Act, it actually would have increased 0.9%. That's actually pretty kind of good evidence that this thing's been effective. Here's some graphic proof. This is the number of approvals every year for new indications for rare diseases. So as you can see, in 1983, we had about 2 that year. Actually, we're running now about 50 to 60 new orphan indications approved each year. When we look at the number of listed, in other words, cumulative orphan indications where people have got a trial going on, things like that, it's well over 730. And, then the number of drugs actually is, like I said, hitting around 600 now. When we look at the percentage of approval of all drugs at FDA, we're about 50 to 60% of the new entities approved each year at FDA across all therapies. So Orphan has really established itself as a driver for people coming to FDA for clinical trials. Now, the number of patients impact obviously is not going to reflect what this graph shows, but the number of new entities does. So there's a lot going on at FDA around rare disease drugs. What kind of drugs are we talking about? Like in almost all aspects, oncology typically will dominate. A lot of the rare cancers and more cancers are defined as rare because of the incident rates. So a lot of the drugs go there, but whether it's inborn errors of metabolism, neurologic, infectious disease, and hematology, vascular, et cetera, that kind of makes up the rest of it. So there's a lot of new things coming out every year, which along with the 10 plus new diseases a week means you've got to keep up with all this stuff. What's the impact on the market? This graph that was done in 2017, I think is a little overly generous since we're in 2022 right now. But the orphan impact on worldwide prescription drug sales is probably right now at about 16 to 17%, with fairly hard data on that. So it actually is a significant portion of pharmaceutical sales now worldwide. So once again, like I said, when you start to hit these numbers, you start to get noticed. The other interesting thing is the clinical economics of this. In medical genetics and rare disease, we're what I would call a thought specialty. We don't have a procedure, we don't cut anything, and we don't scope anything, which means the reimbursement is basically time spent. And as we all know, those tend to be not particularly well reimbursed. We spend a lot of time looking at the impact of our patients on the rest of the healthcare system. And we sort of have become kind of the bread and milk for a specialty pediatric hospital. We get folks in the door because they need to come see us, but then they go back and buy steak and other things. So from a department chair standpoint, having a robust genetics program around really does add a lot. And we've got some really hard data to show that. A great paper by Sean McCandless. I know this goes back to 2004, but the numbers really do hold up. When he looked at admissions across a year at Rainbow Babies, 34% of the patients admitted had a clear genetic condition, a clear rare disease genetic condition. Those patients, however, generated 51% of the hospital billings. And when they looked at everything, they noticed that there was a genetic determinant or a link to something involving rare disease and genetics on about 81% of their hospital billings. So that was an interesting paper. We went back and looked, what were the chances that you would have an ICD-10 for rare disease? We took a 3-year window to look at that and looked at 1.5 visits. If you just come to a children's hospital for your first time, you got a 12% chance of actually having a rare ICD-10 condition. If you get admitted, that goes up to 18%. If you visit that hospital more than once, you got a 32% chance that you actually have an ICD-10 rare disease diagnosis. Remember, since these are typically genetic conditions, that ICD-10 diagnosis means you've kind of got that for life. The net physician charges over time for that were over $4 million. The net facility charges, and remember, most hospitals place a lot of their economic well-being in those facility charges, rear ends in beds, laboratory testing, facility fees, things like that, was $74 million for those patients. Most folks, what were the most common things we saw? Down syndrome, and then actually autism with underlying different genetic etiologies for that. So it's very interesting data to look at. When we looked at what specialties we use, as I said earlier, pretty much everything. Our biggest referral for children's, when we looked at 500 patients that were first seen by genetics, neonatology was a big one, GI, and then it kind of goes around to sort of the usual suspects. Our neurologists tend to not, they've got a geneticist or two in their program here, so they kind of do some of theirs in-house. What about the number of specialists? As you subdivide people into smaller and smaller specialties, what you'll find is you seem to have those cluster in mostly Europe, US, Australia, and Japan, Korea, places like that. And that's kind of true for what we see with the distribution of medical genetics and rare disease specialists internationally. They too tend to cluster in these areas. So what does that mean? So if you live in South Africa, the number of geneticists available is 1 in 4.5 million. Average developing countries about 1 in 3 to 4 million. In the European areas, in Eastern Europe and some of the areas outside that, it's about 1 in a million. And then in Western developed, it's about 1 in a quarter million. Interestingly enough, the estimate is that we actually need about 1 in 50,000. So either we've got to start cloning really fast, or we need to come up with some different models on how we're doing care, because we're not really even close to having the folks we need to meet this rapidly growing field. So what I wanted to kind of set up so far is this field definitely has some challenges. We've got more diseases and longer survival, which equals more patients. We've got an explosion in the number of treatments. We've got an explosion in the number of diagnostics we can do, primarily next generation sequencing. Our patients are going from an acute to chronic model. When I started, we were kind of more hand holders. We would sit down with the family, tell them some very bad news, and then just kind of sit with them because there wasn't much we could do. Now we're actually going into much more active management models. We're dealing with a lot of, chronic care, complex therapies. So that actually becomes much more time intensive per patient. It's very worthwhile because these are great patients. Charlie and I were talking about one of our young patients with isovaleric acidemia he helped me care for. This young lady who untreated would have a devastating neurologic condition, would have most likely killed her in her first year or two of life. Actually is a high school honors graduate who rides horses, actually competes in jump. Recently broke her leg doing that, which I actually take that as a good thing. She's active enough to get out there and do that. So it's very rewarding, but there's a lot of work to do. The other is we have geographic distance and access disparity for our patients. Patients who don't live near a major medical center do not get the same access as those who do. These patients tend to be fragile. They don't necessarily travel very well. So that's one of the things we really need to think about. We also have to start really seriously considering the financial impact of rare disease on the healthcare system. I don't have great answers for that one, but it's something we definitely need to think more about. And of course, we have our workforce challenges as well. So I view challenges an opportunity. And I think in genetics, we have the opportunity to try new models. Since we are a thought specialty and not particularly financially critical to a hospital's function, we can try different clinical models to see actually what might work, what might take care of our patients better, and what allows us to actually deliver best care while working with our colleagues. So how do we face these? Well, collaboration is the biggest one. New care models, technology. And then one thing I think we must do, and I hope there's some primary care providers or general pediatricians out there. My wife is a general pediatrician. We need to start bringing care models back in primary practice. That's where these patients have their homes. The physicians there are just as smart, if not smarter than we are, as my wife will remind me on a regular basis. And we really can actually partner with them to do a lot of the things we need to do. So we can break a lot of the old molds, and frankly, we really don't have a choice but to do that. So what about collaboration? So congratulations to your program for becoming one of the Nord Clinical Centers of Excellence. There are 31 of those nationally. I can tell you without revealing the scores that your program did very well on the national scoring. It is a series of questions. And what it really reflects is the strength overall of your program, because we ask about every specialty. We ask about transitions to adulthood, which with our survival rate for our patients is becoming more and more. And you guys were competitive with the best of the best. Some other collaborations, the World Health Organization, I'm involved with a effort there to develop what do we do for rare diseases in different care scenarios. In other words, In Europe and the US, we can do some very similar things. If I'm going into parts of sub-Saharan Africa, there are places where we can help some patients, and things where we may not be able to do as much, but there are some impacts we can have. How do we do those in a responsible and sustainable method? So that's one thing that's been very interesting. There's also, I'm part of a global commission to decrease. We are horrible at acronyms and naming things. I'm just going to tell you right now. Global Commission in the Diagnostic Odyssey for Children with Rare Disease. And the goal there is to decrease that time to get to diagnosis. The other one is the International Rare Disease Research Consortium, or IRDIC, as we call it. And there's a whole bunch of other groups out there as well, too, including NORD and others. But there's a lot of good collaboration in this field. And given the small numbers of people in the area, we really do have to collaborate. So one thing we do is we take the patient journey and then try to break that down and find ways. And this should be sort of familiar to most of you. You start with symptoms and findings, the medical system's engaged. Then we go into what I call the diagnostic loop. We'll talk more about that in a second. Let's say you come out of that with a diagnosis, or if nothing else, a provisional, I have a disease in this area. We come up with treatment and monitoring plans. And remember that in our field, we have almost as many experimental treatments as we do established treatments. So you can actually end up with combinations of both of those. And our divisional, I think we currently have something like 42, 43 clinical trials going on at any given time. So this is a busy slide, but it's kind of a fun one when you think about it, because the way patients show up around rare disease diagnosis is something's not right. Now, the classic models, they go through the healthcare system where they work with their PCP, who may call out to his expert colleagues to ask opinions about that. They will pull on their relevant experience, internet searches, and anyone who says they're not practicing some diagnostics using internet search is not being completely honest with us. They may know a specialist that have a good knowledge base, and they'll have a tie to a specialty center. And then we get into this pathway where if it's their easy or medium, let's say something like Down syndrome or something like achondroplasia, those diagnoses can be made quite quickly. If it's something by newborn screening that's easy to pick up, like phenylketonuria, those can be made quite quickly. But for a lot of the conditions, particularly neurocognitive ones, things like that, patient typically would come in, someone would propose a diagnosis, testing would be arranged, it would confirm or not. If it was a no, then you kind of get back into lather, rinse, repeat. And this cycle can go on for years because access to specialists lags by 6 months to a year, particularly in pediatric genetics. The other cycle we'll see is the family starts the search, and we'll get a lot of family self-referrals here. They'll use the internet, they'll connect with other patient groups who may give them a lot of help. Sometimes actually these are quite effective if the patient has very specific symptoms on coming through that, then they'll engage the system and get into some of these loops. What I'd like to propose is these loops waste and use a lot of time. One of the things we have found with next generation sequencing is we can go broad a lot faster, but there's a huge caveat on that. The amount of information you get from, say, whole exome or whole genome sequencing is vast, and that's part of the problem. We don't know what most of the answers mean that we get back from whole genome or whole exome right now. So this is not something that's ready to deploy into a primary care practice, or frankly, in most primary specialties right now, simply because it's very nuanced. I would say the most common answer we get these days from DNA testing is maybe, but we can test a lot of things a lot faster as opposed to getting into this loop process. So we are using it more and more. It's becoming more mainstream, but it's not quite there yet. So the challenge around diagnostics is, lack of information and awareness. Well, if there's 10 to 14, new diseases a week, how can you be aware of those? No one. The symptoms can often be somewhat random, and the same genetic condition can have a wide range of symptoms. The diagnostic tools are still limited. Most insurers are still very reluctant to pay for advanced genetic testing. something we're working on, shortage of geneticists. There's not a lot of physician training in rare disease, which I appreciate Charlie for asking me today to come help with that. Poor communication among health providers. Everyone is so busy that sometimes we don't have time to communicate and we'll miss a vital clue or things like that. We don't have great standard criteria for diagnosis, and let's face it, our healthcare system is overly complex. And while we can deliver a lot of health care, sometimes we don't always deliver as much health as we'd like to. So one thing we did is we took each step in this process and we looked at where can we intervene, where can we improve things using combinations of technology, information science, and things like that. And as it turns out, there are a lot of places you can do stuff. And I won't go through all these, but just kind of give you an idea of what we're trying to work on. So let's talk about telemedicine, because I think my field has benefited about as much as any other. We've been pushing telemedicine for years, and we got to do the grand experiment in February of 2020. Since we'd actually been working on it already, we had everyone geared up, all licensed. We had all our SOPs in place. So we did a 24, 48-hour flip of our entire practice and went from doing about 70, 60 patients by telemed to doing 500, 600 a month. So we actually flipped very quickly. What are the advantages we found? And I was just presenting some of this data at a national meeting. Access, we found it did decrease our wait times. It also really decreased our no-show rates as well too. It allowed us to address simple issues quickly. You can get on that phone call very quickly if someone's not having to haul their child in, particularly when they're sick. So it really did allow us to decrease the decision cycle loop on taking care of patients. It saved clinic slots for patients who really had to be seen physically. For one thing that I've gotten more feedback from parents on, we found that our patients with autism, those families, this was one of the most tremendous reliefs to them, because when they were bringing their kids in before, the kids would become violent, sometimes hurt themselves, hurt others, but we actually got to see those patients at home in a comfortable environment. Our dietitians loved it because they could go look inside the refrigerator, and for our PKU patients, say, hey, what's that giant bottle of Diet Coke doing in there? Don't you know that's got phenylalanine in it? And also for some patients, we can increase the frequency of visits, but do them very short and then actually keep them out of the hospital. One thing we noted was that for our sickest patients, our biochem patients, during that time period in 2020, we saw about a 20% drop in hospital admissions. And we think a lot of that is we weren't bringing them out and exposing them to all of the things one runs into besides COVID in a pediatric hospital, as well as the ability to see them very quickly for an acute question or problem. Another thing we found is it removes some barriers to care. A lot of families don't have great transportation, can't get into the hospital. And if they live in a remote area, that's even a bigger deal. For our working families, particularly where it's a one-parent household, we found that the issues around childcare or taking off from work in a job that you might lose the job if you did, that really was a lot easier for those families. And we noticed that those families were now able to come in and get care as well. So it improved, I would say, access to care for a lot of folks that otherwise might not have. We also found some neat things like families where there was an overseas deployment for one of the parents, we could actually have them both in the visit. We also found you can zoom in. I don't know how many of you out there, there's a few I'm hoping, but it's easy to get multiple providers together to see a patient. And we also found for our trainees that during COVID, when they were supposed to stay away, they could still participate. Charlie and I managed the inpatient service there for I think about 4 or 5 months. I was the wheels on the ground inside the hospital seeing the patients. Charlie was over my shoulder, taking notes and throwing suggestions in my ears, and then I made him do all the paperwork. So it was ideal for me, but we were still able to keep our trainees up to speed. Patient impacts, and kind of the stuff we talked about already. High frequency visits for complex patients, less restrictive environments, and really our patient satisfaction was very high with this. We were very pleasantly surprised. One place we found it also had a profound impact was newborn screening results. being able to see a family that same day, because remember, parents with a newborn don't always travel that well. But when you call them up and tell them there's an abnormal newborn screen, maybe a serious illness, that throws that family into a tailspin. So the ability to same day see them by telemedicine, talk to them, get a good look at the baby, make sure everything was going okay there, and that we didn't need to, bring them screaming down the road. Sometimes we did actually have to do that, was really great for those families. Let's talk about some digital innovations we did. So I love this. I'm a fan of peanuts, which means I'm actually old. But this is what families hear sometimes when they come in and listen to us. And we start off by telling them something that's a little bit of bad news. Almost everything after that is womp, 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 which that means they're just not hearing us. So how do we get information about the testing we're doing, complex issues to do that? Well, what we wanted to do is come up with something that would give these families something they could look at in their own time. We originally called this Bare Genes. It's now called Gene Clips. It's freely available in the App Store. I'll show you in just a second. But we came up with a series of 3 to 4 minute videos based on learning theory around genetic testing, risk screening, genetic inheritance patterns, different diagnoses, nutrition for genetic conditions, and even things like such as before your first clinic visit. And this gave these families something they could watch. We're going to give them a prescription, watch these specific videos. They're available on the web as well as a free app. It's now called Gene Clips. The reason we changed it is as part of the National Rare Disease Centers of Excellence, the other centers are actually very interested in using these and shooting those. There's about 30, we just shot a bunch of new ones yesterday. It's about 30 to 35 of these. We rotate out ones as they become old. As you can imagine, the genetic testing one will change fairly often. But it gives the families information about what is a whole exome, what can you expect, things like that. And while it seems like a simple idea, it's actually been incredibly popular. And I look forward to coming up with some new ideas for videos to put into this system, working with your team up there. But it's available on both the Apple store as well as on the Google Play as well too. So you can find it on both places and it's free. The other one we wanted to look at was a little more sophisticated, but where does all the genetic test result go? Well, currently most of it ends up in a PDF file stuck in some out of the way corner in your electronic medical record, and you have to go find it. Of course, it takes a while because those files aren't always named around something that's particularly useful. So Seth Berger, one of our geneticists, started working on this with one of the big EMR companies. I'm not doing an ad for them, but what the way to reliably store these in a predictable fashion. Now, let me take a little break here, and before I tell you more about this, this is what a lot of people think genetic testing can do. This is a Bugatti at an insane velocity. I think it's currently one of the Bugatti makes one of the fastest, if not the fastest, street cars in the world. This is what genetic testing really does do. It's small, it's not particularly overpowered, but it does get you where you want to go. And you can look cool while you're doing it. At least we'd like to think so as geneticists. So there's a gap between expectation and reality. The genetic sequences we do generate vast sums of data, a lot of which we don't know what to do with. So what are the things? So when we look at exons, there's 180,000 exons in the human genome. It's about 30 million base pairs, but it's only about 1% of the genome. When we sequence a human being and we compare them to a reference, we find about 140,000 variants. Most of those are known variants, but a lot of them aren't. So we're finding new things all the time, thousands sometimes of new things in a patient. If we sequence your entire genome, and remember, when we say whole genome sequencing, we're not really sequencing your whole genome. We're doing about 2.6 out of the 3 billion base pairs. Remember too, you've got 6 billion because you've got 2 copies of stuff. We'll find about 150 million variants. And for each patient, we'll identify about 8,500 novel variants. And if, I compared 2 folks, 10 plus million variants between two. The trick there is trying to figure out, which ones mean anything. Then if we start looking at RNA sequencing and mitochondrial DNA sequencing, there's a lot of genetic data that we can generate. And what are the results of that? Well, sometimes it's a change that we find and we make a diagnosis. And we either make it because it's a change we're absolutely certain causes that disease, or one that we can make a very strong argument that the change found will cause that disease. The next one is called no change found. And this one you need to be very careful with, because if you look at what I just showed you up above, we always find changes. We just don't always find a change that we think causes the condition the patient's presented with. So I always get a little leery around that one. And then the third one is one of the most common things we see, if not the most common, which is uncertain changes. You'll see them called variants of unknown significance, or VUS, which has become, I think, one of the words that makes me cringe more than anything, because it means we found something, but we have to go sort of a storytelling and interpretive dance to link it to the condition you have. We don't really know for sure if it caused that condition. There was a great article in, I think, Wall Street Journal and New York Times about a year or two ago, where a family had gone through a series of 3 diagnosis and de-diagnosis processes because variants were found that thought to cause the disease, and then it found out it didn't. Then they found another one they thought it did, and then found out that one didn't. This family had even started a patient advocacy group around that one variation, and turns out that they had to abandon that. The biggest issue we find around this analysis is computer processing and the time of a molecular geneticist to try to interpret this. The image processing of the chips from these, the chips themselves for sequencing, the cost on those is becoming relatively low. I mean, under $1,000 or so. The time to actually process that, sort through those thousands of variants and come up with relevance, that's actually where most of the effort and everything is being spent these days. So what we thought would be useful is a way to actually store the variants found on a patient in the electronic medical record, but actually in a way such that it is linked to the national and international variant databases, which are constantly being updated. So that's where we came up with this thing called Discrete variant capture. Works really nicely. The nice thing about this is if a variant changes from uncertain to certain, or from unknown to likely to cause disease, that actually updates in conjunction with that patient's electronic medical record. I think this is going to be a real safety issue for our patients. It also means that when we're trying to find patients with particular changes, to either go back and change a clinical therapy because we found something that might work better, or to identify patients for studies, we'll also be able to do that as well. So that's been actually a very fun project. The next step on this one is what we call PDF Parser, where we go back and take the PDFs. We've been working with a company that does, I think, exquisite data extraction from PDFs in this fashion. It pulls out, it lists what it thinks the genetic variant is, puts it into proper nomenclature, and that's a really big deal. You got to make sure it's in there the proper way, and then a person looks at it before it finalizes, because as you know, if you don't do that, you can compound your errors pretty quickly. So that's one of the things we're doing to try to make sure that DNA data is in there and then relevant for the future, because you always have the, oh gee, 5 years ago, didn't we sequence that patient or not? This is a way to make sure they did have that. And that's done in a fashion so that other large EMRs can use it as well, and something called Smart on Fires or FIRES. The last thing I want to talk about is a new project that we started in the last 2 years called RareCAP. Those of you who do any type of clinical research or work with the CTSA are probably very familiar with RareCAP. This is not an accident, and I'll explain why in a second. One thing we did not have was we did not have a good generalizable protocol storage place for rare diseases. We have some pretty good ones, but given the fact that we're doing 10 to 14 new conditions, we didn't have a place a week. We didn't have a place to roll out new protocols very quickly. The other thing is a lot of those protocols were not designed to involve the primary care providers or what I would call more of our frontline folks. So what we're working, and we're building actually the digital platform now between my team and then the team at Vanderbilt University, which is where RareCAP comes from originally, is a platform and database of rare disease protocols using library calls for a lot of the things we'll be doing to the patients, so you can reuse them again and again from that. But it's got a little bit of a neat twist. So the way I like to describe it, it's Wikipedia meets Reddit meets RareCAP and WordPress. So there's a core protocol for what we're doing with the patients, but the margins, the user can actually put comments in there for what they're doing, why they're doing it, what they think this should actually be done. And then the other users can comment on those comments, and the moderators can actually bring those into the protocol if they gain enough mass. Some of you who are used to doing evidence-based medicine should now be piling up the wood and getting ready to throw matches in it to burn me up. Let me explain something about rare disease that we've observed over the years. And this, I think, is a fairly general observation. When you look at your Delphi criteria or your ABCD level criteria, or whichever system you like to use, level A evidence is meta-analysis of huge studies. We don't get that in rare disease. Level B is large series, like tens, hundreds of thousands of patients in a single study. We don't get those in rare disease. Level C evidence, which is published literature, is tricky in rare disease. We'll usually get an initial description of a new condition of the first handful of patients. But after that, the most of the publications actually tend to deal with the patients who have that disease with an exception. Something weird happened elsewhere. So if you end up using the published literature, a lot of times you can start doing what I call teach to the margins. So you'll use that original, but also then all of those variants. So you'll put in screening in place that may actually be extreme and not really that appropriate. And then D is your expert opinion, the folks that are out there doing this day to day. That data is not as bad as you might think it is. Yes, it's not always evidence-based, but a lot of it's based on real world experience. The nice thing is you can use that and build a living document. So you've got your Wikipedia base, you've got your Reddit base on the margins there, so that that treatment protocol can grow and develop with time and improve. And then as published evidence comes in that's relevant, that actually can pull that in. So this is an ambitious project, but it's well underway. And we hope to be bringing that out in the next year or two. I know Dr. Sue Berry there has someone who I've relied on for a lot of good advice on this. And this is something also that we'll be working with on the Centers of Excellence as well too. Finally, let me talk, how do we deal with areas where they don't have all the things we have? So one thing we do is we go to Uganda every so often with our cardiologists, and we'll end up seeing 200 patients in a week or so, a lot of whom, we can diagnose because they have something like Down syndrome, they just didn't know it. A lot of whom, if we had some simple testing, we might be able to help, but doing even a simple chromosome study would take that clinic's budget for a month. By the way, I do have the permission of the folks in the picture to share their picture, by the way. So one thing we did is we came up with a facial recognition program that was fairly cheap. We actually worked with this in Latin America, South America, the Middle East, Sub-Saharan Africa, as well as the Mediterranean, as well as in the United States, and came up with some relatively robust facial recognition software for doing kind of your common 5 or 6 most common genetic syndromes like Down syndrome, Williams, DeGeorge, Noonan's, fetal alcohol syndrome, things like that. Some of that we've been collaborating with NIH as far as publication in an atlas. The folks in the Emirates were very interested in helping us with this also because they also saw the need in those regions. And some of these are pretty accurate. The Down syndrome one in newborns can get as high as 97, 98% accuracy, which is probably better than a general practitioner and about as good as my really experienced geneticist. So it was a little scary how good it was, but that's something we're moving forward. And then other things, let's say that you need to measure ammonia at home. Well, if you've got a child with a urea cycle disorder or something where ammonia goes up periodically, every time they get the sniffles, you can't haul them into the emergency room and get an ammonia. Well, they do now, to get it checked. But remember, every time you haul them into the emergency room, if they didn't have a virus beforehand, they will probably by the time they go home. So we worked with the University of Maryland doing some microfluidics to measure ammonia, came up with something that actually, in spite of this breadboard look, actually is convertible into a home unit for doing these things. So you got to be really creative in this field. And the way I view it is the glass is always full, and it's a mix of air and water. I think right now we got a lot of water in the glass. I tend to be fairly optimistic about these things, but I do think my field is one of the most vibrant and probably one of the most interesting fields out there. So with that, I am going to call to a close, and then let's see what we've got in the question board. Charlie, you want to come online with me and let's see what we can do.
Yeah, I'm on. Thank you, Marshall. This has been great. I wonder if you can tell me a little bit more about some of what you were talking there with the discrete variant project in the EMR. Are you able to start bringing in data from exomes and seeing those variants reclassify as things are being reanalyzed?
Yes, and if that's actually
happens on one patient, does it happen on the other patients as well?
Right. And that's exactly what we're starting to see. So we have also worked with some of the large sequencing laboratories. They're willing to put data directly into this system so that it will populate into the EMR. It's going to be neat because it's going to be basically a new type of lab report that's populating discrete data fields in the patient's record that then have a active link back to these databases where, kind of like ClinVar and some of the others where it's kind of this friend or foe determination. So it's a very new thing, but yes, the answer to your question is yes, Charlie.
Thank you.
I will ask question. That was so great. I'm a
Oh,
general
thank you.
pediatrician, so I'm here to answer your wish for general pediatricians in the audience. I really loved that bread and milk analogy. That was incredible. I am not a healthcare reimbursement expert, but I thought I had heard that there's some CMS changes coming down the pipe in terms of RVU reimbursement for cognitive versus procedural specialties. And I just would love to hear your thoughts on private payers following that path, and also pediatrics versus adult medicine and
Right.
what you've heard.
So one of the reasons I moved to DC from my hometown of Nashville, Tennessee, which otherwise I would never have done, was actually to get involved in trying to hopefully try to move some of the discussions around this. I can tell you there are a lot of efforts to try to make that shift away from procedural towards cognitive. I can also tell you that in both the medical field and in some places in Congress, CMS, and others, there's a lot of resistance too. Those who currently collect off of procedural don't really want to give that up. So, they're okay if we get it too, but the problem is the pie doesn't have an unlimited number of slices in that. So I suspect it will not be the easiest battle. And they've got more cash than we do to fight these sorts of things. So that's one thing. The other is, I think the payers learned a really interesting lesson. And I've talked with the folks that handle rare disease and actually the world's largest, well, at least the US's largest payer, which is up there in your area, and then a couple of others. And they're becoming much more nuanced about the impact of good genetic care and good specialty thought care for our patients. And they're starting to realize if you do that well, that actually may save a for instance, telemedicine and a lot of the things we did there with these drops and admissions saved them tremendous amounts of cash. But there's something you've got to remember that my wife was actually the health policy director for Senate Finance Committee for a number of years and learned some interesting lessons. One of which is in Medicaid, children are 60% of Medicaid enrollees, but they're only 20% of the costs in Medicaid. So getting that attention to the pediatric population is very difficult. One of the things that oddly enough is helping is our patients are becoming older and becoming adults. A lot of them are very good at self-advocacy, but also they're just showing up on the doorstep of internists and they're suddenly being confronted with I won't call it a wave, let's say maybe a ripple of patients who have things they've never heard of before. So we're starting to get the attention, I think, of some of the broader fields of medicine. It's going to be a slog, though.
Dr. Lund from our BMT division asks, congratulations on your excellent talk, and then mentions job loss among families with rare disease, but also wonders if there are data about family stress due to rare disease leading to separations, divorce, and substance abuse or other mental health diagnoses.
There's actually a fair amount of data on this. Obviously, there's a lot of data in the cancer field as well, too. So I suspect that may be where that's coming from. We've found kind of two reactions that we would see, and it's not exactly binary. In some cases, a new child with a rare disease pulls a family tightly together. Everyone kind of realizes that they've all got to pull an oar there, and they actually kind of team up and get those things done. In some of our other families, it does seem to drive folks apart, particularly given the long term of these rare diseases. And we used to have this concept we call the iron ring, which was one parent would develop the care expertise around a complex child and would start to lose trust in almost anyone else taking care of that child. And they would become more isolated inside this little ring of care, and even pushing away physicians, family members, spouses. And we saw those often end in the breakup of the family there. Also, obviously, severe impact on the siblings as well, too. As you're probably aware, too, they've done a lot of studies on Down syndrome families, impacts on siblings, and it's not a trivial thing. So the answer is yes, we do see an impact. Financial impact, I used to see families go bankrupt. I don't see that very often anymore. I would say we've become more sophisticated, and the system's become a little more adaptive to helping us take care of these families.
And then Dr. Orchard, also from BMT, wants to know a little bit more about the opportunity for the newly established Rare Disease Centers of Excellence to pool resources and expertise in terms of data management, and then potentially collaborate on national policy advocacy.
Dr. Orchard, it's good to hear from you. I know you have been a fan of the Centers of Excellence model from day one. Yes, there are going to be those opportunities. We're actually going to be convening in Cleveland this summer for the centers. And of course, obviously someone from Minnesota will be there. Data pooling will be very interesting because first off, herding cats is always entertaining, but we actually have a neat opportunity. NORD has the I Am Rare program, which I think currently has about 60 rare disease natural history studies that are primarily patient-entered data, but now we're going to start morphing towards having care provider entered data as well too. So I think taking some of those for data sharing, there's going to be a lot. Projects like the protocol program I showed you, I think will become kind of one of the core entities in that. So everyone can kind of chip in on really trying to optimize a lot of these care plans we're doing. So yes, I think there absolutely will be those opportunities. That was one of the purposes of doing it in the first place. What else you got for me, Charlie?
We have one last question, but I think we're at time. So thank you, everyone. If people are interested in joining Marshall afterwards to talk more, there's the Zoom information in the chat. But just before we head off to that, Dr. Berry wonders, what do you see as some of the best strategies for engagement of our adult medical colleagues? You talked a little bit about that already, but if you have any specific ideas for how to build that bridge, I think we would all love to hear those.
Yeah, abject fear of dumping a patient on their doorstep is probably not the most effective strategy for doing that. We are training a lot of geneticists now who have dual training in adult or family medicine training or med peds or just straight up adult. That will help some, but getting awareness in the general medicine community or just internal medicine community has been kind of hard to do. I think some of it is we'll find sort of beacons of light. And one of the things, let me explain what I mean. We found internists who want these interesting patients. And that's actually the hook. The hook is these are patients that have complex and interesting diseases that are intellectually stimulating and are not, someone with a cold, cough, or bronchitis, or someone who's hypertension or obese, things that maybe don't necessarily engage them intellectually as well. So what we do is we try to go out and find those folks who have a lot of curiosity about the world and then rope them in. The patients tend to sell it themselves. When you come in line and say, hey, I've got a patient with N5, N10 methylene tetrahydrofolate reductase deficiency who has these kind of odd things that happen to them, you're going to find internists who go, ooh, that's really cool. And you're also going to find ones that don't want to have anything to do with it. I think that, hate to use the term slog again, but it's a bit of a slog.
Well, thank you, Marshall, for presenting
My
today.
pleasure.
Just a bit over time, but it's been a great pleasure, and we're excited to have you back again sometime. Maybe not in this snow.
Okay, I look forward to coming out and seeing you. Like I said, you guys having Charlie, you've got one of my favorite all-time young geneticists. Take good care of him, because if you don't, I'll come take him away from you. Now, Charlie, go negotiate your salary. All right, so we'll switch over to
announcements.
No, that's it. Don't forget to come to press. You cannot have Dr. Billington. He is ours. And also, sure, you can try to negotiate your salary. We should all do that.